First, I'd like to introduce our speakers. So it's Rachel Taylor, and Rachel is a consultant nurse and the clinical lead for Huntington's disease at University College London, and Stefania Bruno. And Stefania is a consultant neuropsychiatrist, also working at UCL.
Thanks for the introduction, John, and thank you everyone for joining. And it's really good to be able to meet you virtually. So we're here. Myself and Stefania are gonna talk a bit about medication, and it's fantastic. There's so much interest, because medication it can sometimes feel a bit like squiggly lines and funny loops and all sorts of things to all of us. So I think it's a really, really important topic. I'm going to talk a little bit about why we often use medications to try and manage symptoms of Huntington's disease. Just to say, we're talking about medications that we currently have available, so medications that are for symptomatic management. We're not going to be covering experimental medications or medications that are in clinical trials. So just obviously to let you know about that. We're also going to talk a bit about why we sometimes don't use medications, and the reasons for that. We're going to talk about some of the medications that we commonly use to try and manage symptoms. And then I'm going to hand over to Stefania, who's going to talk more about psychopharmacology in Huntington's disease. And then we've got a bit of time for questions. But again, just to say, we can't provide any individual clinical advice in this session. So why do we use medications? Why do we sometimes pick medications as an option to try and manage symptoms? Well, we want to try and relieve distressing or problematic or harmful symptoms. That's really the goal. And the reason for that is that we want to try and maintain or improve quality of life. We want to try and improve or maintain a person's functioning, how they live in their daily life, and that can then help with that person's independence and ability to live their life. We want to try and maintain or improve comfort, and also sometimes with medications it's about improving safety for the person or the people around them. And we want to try and prevent a crisis situation. And I'm sure, as everyone who's listening in knows, sometimes some of the symptoms that Huntington's disease can cause can mean that situations can become unsafe if we don't try and manage a symptom properly. So they're the reasons why we may look at, is a medication the right thing for this person? But likewise, sometimes we don't use medications, and there are many reasons for that. I think, you know, all of us, if we look at the potential side effects, even on something as seemingly harmless as paracetamol, if we read the side effects, we probably wouldn't ever take it. But it is really important that all of us who are prescribing medications, taking medications, are aware that there are side effects, and sometimes those side effects mean that actually that drug, that medication, isn't suitable for us to use. Sometimes medication, as strange as it seemed, can actually make a symptom worse, and we need to be very aware of that, very mindful when we're prescribing medications for people. We also know that a lot of people that we see are on lots of different medications, and sometimes that's for the symptoms they're experiencing with their Huntington's disease. Sometimes it's because of their Huntington's disease symptoms and other health conditions that they have. And And the thing when you're on a lot of different medications is that they can all start interacting with each other. They can make medications either work a little bit more than they should or not work so well. So that can cause problems too. Some symptoms of Huntington's disease don't respond to medication, and we know that. And although we're not covering our non-pharmacological interventions today, so we're not going to be talking about all the other things that that we can do to try and manage symptoms, it's really important that we acknowledge that there are symptoms that don't respond to medication, or that could be better managed, or at least we should try and manage them not with a medicine in the first place. Some medications aren't suitable. We can't use those medications, and when Stefania talks a bit more about some of the medications used for the psychiatric symptoms, some of those medications aren't suitable if you have other health conditions. So again, it's really important for us to be aware and to take a full history from people. Sometimes we think that by increasing doses of medication, the symptom will go. So, well, it hasn't worked on this dose, but we're going to keep increasing the dose. And sometimes we know that actually if a medicine hasn't worked at a certain dose, it's unlikely to work at a higher dose. And again, I mentioned that actually sometimes it's better to try other options first before we try medication, for all of the reasons that I've just talked about above. So the side effects and the polypharmacy. We also have to acknowledge that actually a person with HD might not want to take medication, or they may not feel that that particular symptom is an issue. And we'll talk a little bit more about that. And sometimes it's very easy when you have any kind of health condition to blame that health condition for all the problems, for any symptoms. And we know that, and I'm sure all of you know, that actually when you have a condition like Huntington's disease, if you get something else, it can make your symptoms suddenly much worse. And so lots of times we maybe get contacted because a person's symptoms have suddenly got worse. In a couple of days, their movements have become much worse. And actually, when we talk it through, they've got an infection or something else that's going on, and that's exacerbating those symptoms. So it's really important that we don't, as a knee-jerk, suddenly increase medications. There's other things that we also need to think about when we're thinking about medication, when we're thinking about prescribing medications. So again, I mentioned if the person doesn't want to take a medication, do they need to take it? And if they do need to take it, what might the options be to encourage them or to ensure that they do get medications that they need? We also need to think about whether the person can take the medication. Are they able to swallow a tablet? Does it come in other forms? If a person has got a feeding tube, for example, are we going to block that tube if we continue to give them a medication? So that's really important to think about. How the person will manage to take their medication. How will they get it? Will they remember to take it? Do they need something to help them to remember to take their medications? Actually, just very simply, can the person actually open their medication packets, or is there somebody that can help with that? And I was taking some paracetamols out. Actually, those packets are really, really difficult to get into. And if you have some coordination difficulties or some movements, we need to think about that. Does the person know when they should be taking their medication, how they should be taking it? Things like paying for prescriptions as well. is a person entitled to having free prescriptions? If not, can they afford medication? The other thing that we come across sometimes with some of the medications that we may be advising or suggesting is whether primary care, so whether a GP is actually able to prescribe the medication. So it can sometimes feel like, well, you know, my GP won't prescribe this, and actually it's not that simple. It's we can only prescribe from formularies, and if a medication isn't available to be prescribed, that can it's very difficult then for primary care to prescribe those drugs. So we have to always be mindful of that as well. Is the medication available? So sometimes there's a shortage of medications for various reasons, and that might mean that the local pharmacy isn't able to source that medication. So the prescription is there, but they're just not able to source it. And another thing that we need to think about is, does the person still need their medication? Often people get started on a medication for a symptom, and as symptoms change over time, they might not need that medication, and so really important to keep reviewing, is this still needed? Is it still valid? So thinking about some of the symptoms of HD that we might try and manage with medications. So some of those would include the motor symptoms, so some of the physical symptoms, sleep disturbance, excess saliva, bowel and bladder symptoms, and then the neuropsychiatric symptoms. So I guess the motor physical symptom that we think about the most when we think about Huntington's disease is chorea, those abnormal involuntary movements that people can experience in varying degrees. And the thing that we should always ask somebody when we're thinking about whether or not to prescribe a medication to try and manage chorea is whether actually the chorea is causing distress or disturbance to the individual. And because sometimes people will say, actually, my movements don't bother me, or I don't really notice them. Other times people will say they really cause me distress and I'm very aware of them. So for this particular symptom, it's very important to work in partnership with the individual and really find out whether this is something that's bothering them. As a first line, and actually the drug that's it's actually licensed to manage chorea in Huntington's disease is tetrabenazine. And I've put there it's not suitable if a person has poorly managed depression or any kind of suicidal thoughts. And I'll talk a little bit more about tetrabenazine because it's a commonly used drug. Alternatively, we use drugs called neuroleptics. I'm not going to cover those because Stefania is going to go into those in much more detail. So yeah, so tetrabenazine is licensed in the UK for the movement disorder in Huntington's disease. It works by causing a reduction of a chemical called dopamine in the brain, and dopamine is sort of known as the feel-good hormone, but it's also involved in movement. So if we reduce dopamine, it can lead to a reduction in chorea. So it can be really helpful. However, the reason it's called the feel-good hormone, if we reduce dopamine, then it can result in a lowering of mood and depression. It can also increase stiffness because we're lowering movement, and it can cause sedation. So it's really important that if we're considering using a drug like tetrabenazine, that we assess somebody's mood, if they have untreated depression, if they've got any suicidal thoughts, then we would avoid tetrabenazine. We always start with a really small dose, a dose that probably wouldn't be effective, but we then slowly increase it as long as there's no side effects. And we monitor really closely and review, and that's very, very important. Some of the other, what we call motor symptoms of Huntington's disease. So people can experience rigidity. So that's an increase in their muscle tone. And the first thing we do is, are they on any drugs such as tetrabenazine, which could be making them more stiff? Because actually, do we need to think about reducing that? We sometimes use levodopa. So this is a medication that's used for Parkinson's disease quite a lot. And although this is a rarer symptom, some of our younger people who develop Huntington's disease may experience a more of the rigidity and less of the movements with their Huntington's disease. So we would maybe consider using levodopa for that. Dystonia is another symptom, and this is a sort of abnormal posturing, and it's often associated with rigidity. And sometimes we may refer people for botulinum toxin injections, which can be useful for a specific area if it's somebody's hand and it's particularly painful. We also, people can also experience what's called myoclonus, so sudden muscle contractions. Again, we might use drugs that come in the group called benzodiazepines, and Stefania will be talking a bit more about those. So in particular, clonazepam. But again, always have to think about the side effects of those medications. And people might experience spasticity. So this is an increase in muscle tone, a stiffness or a tightness in their muscles. And sometimes we might try something called baclofen. And this is a drug that can be taken orally, or sometimes we might refer to our colleagues who are real experts in managing this. And they can give baclofen via an injection into the spinal canal. Another problem that for a lot of people we see in clinic are sleep disorders, and actually they can affect around 2/3 of people with Huntington's disease. And this can vary from difficulty falling asleep, waking in the middle of the night, reversal of the day and night time. So people are asleep all day and awake all night. And it's complex. It's very complex. There are a lot of different causes for sleep problems. And it's really important that we investigate and we try and find out why someone might be sleeping poorly. Poor sleep hygiene is another thing. And as I said, we're not really going to be focusing on non-medication interventions, but particularly with sleep, it's really important to think about other ways, cutting down on caffeine and other things that can improve sleep before we go down the medication route. And again, really important to weigh up the pros and cons of medication due to side effects, because obviously if we're going to prescribe something to help with sleep, the sedative nature of it may increase people's falls risk. It may make them feel a bit more confused, a bit more sedated during the day. Some of the things we do consider are, hypnotic sleeping pills, melatonin. So we do know that the alteration of the sleep-wake cycle in people with Huntington's disease can be due to an alteration in the production of melatonin, which is a hormone which contributes to us feeling sleepy in the evening. As I mentioned earlier, this is one of those drugs that it can be difficult for primary care to prescribe because it might not be on the formulary for where somebody lives. So melatonin, it can be helpful, but it's not without its problems in terms of prescribing. I will leave Stefania to talk about things like antidepressants that may help with sleep. Sometimes people use antihistamines, but again, as I mentioned, it's the pros and cons of medication due to side effects. Another problem people experience potentially later in their Huntington's disease is excess saliva, and that can be really troublesome. Again, we weigh up the pros and the cons about whether we want to try a medication, because actually if we dry up saliva too much, then people may have problems with dry mouth. It may affect their swallow. They may end up with things like dry eyes as well, dry skin. So we always would look at alternatives first. But if they don't work, and if somebody is being really troubled by excess saliva, then we have some medications that we might try, and these come in oral, patch, spray, often used on or under the tongue. Another thing I did want to mention were bowel and bladder symptoms. Constipation is something that it's really important to manage. It's a common cause of symptom exacerbation for people with Huntington's disease. As per NICE guidance, dose, choice, combination of laxatives that we would recommend using depends on the person's symptoms, the response to treatment, and personal preference. But it's a really important symptom to manage. Bladder, again, urinary tract infections, a common cause of Huntington's disease, symptom exacerbation, and it's very, very important. Any signs of a urinary tract infection, that those are managed accordingly. With urinary incontinence, it's important to investigate what's causing it. If it's related to overactive bladder, urge incontinence, sometimes there are medications called antimuscarinics that could be helpful, but the potential for side effects, again, weighing up the pros and the cons, particularly because they can cause things like increased confusion. So I'm now going to hand over to Stefania.
Hello, everyone. I'm just going to talk about psychiatric medications in Huntington's disease, why we use them, and what are the desirable effects, but also the side effects and pitfalls. So before I go ahead with the talk, I just wanted to remind everyone of some common terminology that we'll refer to again in this talk. We know that our brain cells are called neurons, and the neurons communicate with each other through chemical messengers, which are called neurotransmitters. And there is a communication structure between the neurons, and it is called synapse. And this is like a simplified version of one. And as you can see, the neurotransmitters are carried in these vesicles, and then they will be released into the space between the two neurons, which is called synaptic cleft. And then the second neuron will pick them up, and they bind to the receptors. And once that happens, then there is a signal from this neuron, second neuron, which is activated. I mean, given the limited time, I'm only going to speak about the three kind of most common classes of psychiatric medications that are used often in Huntington's disease. And so I'm just going to talk about neuroleptics, antidepressants, and benzodiazepines. So this is a list of neuroleptic medication that is similar to the one that Rachel showed earlier. The three top drugs are called second generation antipsychotics because they were designed with the aim of reducing some of the motor side effects. Aripiprazole is even newer and actually acts with a different mechanism, which I'm not going to go into. And instead, haloperidol is a first generation drug. And really, nowadays, it should be used only for rapid tranquilization for severe agitation. But unfortunately, sometimes we still see that it is used despite a fairly unforgiving side effect profile. And as well of the therapeutic effects of these medications, I also want to discuss three concepts. I think we are putting a lot of emphasis on side effects. I also want to mention the concept of the therapeutic window, which is very important for this class of medications, and also age-related changes. So these medications mainly act through blocking dopamine, and Rachel has already mentioned dopamine, and it is in fact a key substance in Huntington's disease because, as we said, excessive dopamine activity causes chorea, which we call a hyperkinetic movement disorder, meaning there is too much movement, and this is seen in the initial and intermediate stages of Huntington's disease. And blocking dopamine, you reduce chorea. And I think Rachel has already spoken about this, that the actual only treatment which is licensed for chorea in the UK is tetrabenazine, which is very effective. Now I pinched this photograph from the internet, and I didn't identify any copyright infringements, but if there are some, it is for a good cause. So as you can see, there are two mechanisms for which tetrabenazine works. Essentially interferes with these vesicles that are trying to bring the dopamine to the space for the dopamine to be released. And the medication also binds, instead of the dopamine, to the receptors on the second neuron, which is called postsynaptic. And by doing that, prevents any dopamine that made it through the cleft from attaching itself to the receptor. And this is all well and good in that it's very effective for the reduction of chorea, which we want. But the problem is that the dopamine is part of a larger family of neurotransmitters, which also contains serotonin and noradrenaline. And the tetrabenazine has the same effect also on these two. And these two actually are sort of key substances for mood regulation. I'm sure a lot of you will have heard about, particularly serotonin. And therefore, you are depleting the serotonin and the noradrenaline as well as the dopamine. And this can cause pretty severe depression. And I think this is a side effect that we see relatively frequently in clinic. So it's very important to keep it in mind. And in fact, on the BNF, tetrabenazine is actually contraindicated if somebody already has a depressive disorder. And this is why, in many cases, we are having to use neuroleptics as sort of first port of call for chorea. So, looking at what are the sort of desirable therapeutic effect of neuroleptic medication, so the main effect, which is the main effect for which they're developed, is that these are antipsychotic drugs. So they're very effective in the treatment of psychotic symptoms, like delusions and hallucinations. Now, psychotic symptoms are not very frequent in Huntington's disease. They occur in about 5 to 10% of people, but we do see them. And when they're present, first of all, they can be very distressing to the individual and quite also scary for family. But also, it's just a very dysfunctional state of the brain, which in brief is not good for you. So it's really important to treat this as soon as possible. And another desirable effect, which is true for some of the neuroleptic medications like olanzapine and quetiapine, is that they have mood stabilizing effects, which at times can be very helpful. Now, most of them are quite sedative and would make you sleepy even if you take it in the evening. But the NICE guidelines say quite clearly that they should never be prescribed as sleeping tablets. And you'll see why in a second. But the downside of these medications is that they have a very wide range of possible adverse effects. I mean, some of these are not very common, but I'll just mention some that are common and also relevant, particularly in Huntington's disease. So, for example, the extrapyramidal side effects. So this means that one of the motor systems of the nervous system is involved, and there can be acute movement disorders like dystonia or dyskinesias, and this can mimic chorea. So they may be missed as side effects. But also, more importantly, they can also cause, in the longer term, what we called a iatrogenic Parkinsonism, which means a drug-induced Parkinsonism with tremor and rigidity. And obviously, in the later stages of this disease, where these are neurological manifestations of the illness, we would then make them worse. So it's very important to be aware of this. And the other, linking in with what Rachel said, the other problematic side effect are anticholinergic effects, which are essentially dry mouth, constipation, blurred vision. And I think it's very important that if these symptoms appear in somebody where they are at the stage of the illness where they are not able to clearly express themselves, the risk is that we are actually going to increase the dose in response to agitation or distress, but we are actually making the problem worse. I just want to also mention, and in the next slide, a little bit more detail on the cardiovascular possible side effects of antipsychotic medication, because obviously they're very important. We are all subject with age to sort of aging of our cardiovascular system, and some of the underlying conditions that can be worsened are very common, like, for example, diabetes. So I just wanted to tell a bit more about this. Very quickly, I mean, this could take a long time to kind of discuss more in detail, but I think these are those that is good to just keep in mind. So very common is weight gain, which at times in Huntington's disease may not be a bad thing. But unfortunately, with that, we also have impaired glucose metabolism, which increases the risk of diabetes. And that is something that could potentially be a significant problem. Very common with some medications, particularly quetiapine, is postural hypotension. And this is the drop in blood pressure that you have when you move from a kind of lying or sitting position to standing. And it's dangerous, particularly if you have poor balance, because there is a risk of fall. Then you have some arrhythmias that gets picked up on ECG. And the effects of these are that can be things like dizziness or syncope, but also more concerning problems like ventricular fibrillation, which can lead to cardiac arrest. And what's important to keep in mind is that it is not uncommon that people on this sort of medications will also be on antidepressants that have the same effect, like, for example, citalopram, and in which case the risk is increased. So it is very important for general practitioner to be aware of this and to monitor with repeated ECGs. And essentially, if once you get in the danger zone, you have no option but stopping the medication culprit. And the other thing, which is not widely known, is that there is a significantly increased risk of DVT with antipsychotic medication. And that is particularly important if there is reduced mobility, which unfortunately will be the case in later stages of the disease. So something else to keep in mind and be quite alert about. Now, the good news in all this is that the side effects are mainly dose-related. So if you stick to small doses, you are on fairly safe grounds. And I think it's useful to look at this figure from some very good papers, which shows that essentially the effectiveness of these medications is related to how much of the dopamine receptors they sort of occupy. And this, the best kind of efficacy, it's when 60 to 80% of the receptors are occupied. If you go to higher doses, and therefore more receptors are occupied, you don't improve the efficacy. You only get more side effects. The efficacy is plateaus, which means that essentially it is completely irrational to increase the doses over and over. And the other point is that everyone, all of us, with age, will lose this some of the dopamine receptors, which means that this therapeutic window moves down. And so the doses have to be decreased with time. And in fact, very often I see in clinic exactly the opposite, that over time, in the sort of knee-jerk reaction that Rachel was mentioning earlier, trying to treat some symptoms, these doses go up and they stay up, and instead they should be reviewed and decreased regularly. So that you can see that that's very important message. Moving on to antidepressants, I mean, this is a huge sort of field. I'm just going to touch upon some of the most common ones that you may have come across. There are sort of the most common ones nowadays, and this is because they are the safest. They have a fairly safe side effect profile, are the so-called SSRIs, which means selective serotonin reuptake inhibitors. And so essentially what they do is that once after, like we said earlier, once the neurotransmitter, in this case serotonin, has been released in the synapse, so in the synaptic cleft, and has been picked up by the second neuron, the excess of the neurotransmitter is taken back in the cell, and it is sort of destroyed to be reused. And what this drug does, essentially interferes with this, as you can see here, interferes with this proteins that take it back in, and so it stays in bigger amount in the synapses, and therefore becomes more available for use. And that is how they work. And these are the most commonly used ones: sertraline, fluoxetine, and citalopram and escitalopram. These were very similar. Then you have, and these normally are recommended as first line of treatment for depression. The SNRIs essentially work with the same principle, but this time it's not just the serotonin that is made more available, but it is also noradrenaline. And in fact, these medications are more effective, but this comes at a cost in that there is a higher likelihood of adverse effects, in particular high blood pressure. And that is something that I've actually seen not infrequently, so it's something to keep in mind. And then a very good medication to always consider is mirtazapine. Mirtazapine doesn't work, is a completely different pharmacological mechanism. It is a so-called alpha-2 agonist, so it doesn't really, it's got nothing to do with serotonin. And because of this, some of the common side effects of SSRIs, for example, gastrointestinal side effects, are not present with mirtazapine. A few points that I want to make about antidepressants is that, first of all, the NICE guidelines tell us that if the depression is mild, antidepressants should not be the first line of treatment, and the psychological therapies are known to be very effective at this point. As we've seen before, when you on the neuron, the neuron is exposed to the antidepressant, the brain always tries to rebalance. So you always have initial opposite effect. And in fact, in this case, the neurons activate some called autoreceptors that trying to kind of undo what the antidepressant is doing. And so for the antidepressant to actually work, it takes up to 4 weeks. And so this is very important because sometimes there can be a lot of pressure to increase the dose of medication before the 4 weeks. And it is unhelpful, and people may end up on high doses of medication that are unnecessary. I think, so Rachel has briefly discussed this. So this is particularly shown by research for antidepressants, is that if you choose a specific antidepressant and that antidepressant after the 4 weeks has not worked at all, it is very, very unlikely that it is going to work if you increase the dose. So essentially, it's better to change to a different compound. Now, there are some antidepressants are very good medications. They're very effective. About 70% of people will respond with the first antidepressant that they try, and the 30% that haven't responded, 70% of those will respond to the second antidepressant. So it is very, very effective. And also, unlike other drugs, like, for example, benzodiazepines, with the antidepressants, those that we use, all those actually that are licensed in this country, there are no effects of tolerance or dependence. So tolerance, and these are the two kind of key components of addiction. So antidepressants are not addictive, although particularly if one is on a higher dose, it is possible to experience discontinuation symptoms if they are stopped suddenly. But the tolerance and dependence, which are the kind of pharmacological concepts attached to addiction, are to do with the fact that you have tolerance when the same dose of medication becomes ineffective, and because of biological changes, and you have to increase the dose to obtain the same effect. So you are in a kind of spiral toward high doses, which is very dangerous. Now, as I said, the antidepressants are in general very safe, and in fact, I use them a lot, and very rarely people report significant side effects, and often milder side effects are very transient in the first few days. But the ones that I want to sort of emphasize, just because they are a bit more worrying, are to do with bleeding, because essentially, like we said, that the SSRI inhibits the reuptake of the serotonin in the neurons. Actually, it does the same also in other cells, including the platelets, which are behind the aggregation on the systems of blood clotting. And so interfering with that increases the risk of bleeding. And when is this particularly, a particular problem? Obviously, people already have a history of predisposition to stroke, or if people are on other medications with the same effect. And some of these are obviously anticoagulants, that's pretty obvious, but also non-steroidal medications are commonly used painkillers. So it's really something to kind of be aware of. The good news is that, for example, this risk is essentially virtually absent with mirtazapine, because mirtazapine, as we said, doesn't work through the reuptake of serotonin. It works in a completely different way. So, in fact, I work in this hospital in a neuro rehab where I see a lot of stroke patients, and mirtazapine would always be my first choice in those patients. And it would be in anyone where there is a risk of bleeding. But as you can see, there are some commonly used SSRIs and duloxetine SNRI that can increase the risk of bleeding. So that has to be kept in mind. And that is why I am always very much against sort of random change of antidepressant medication. And it has to be thought through very carefully. So lastly, I'm just going to discuss briefly benzodiazepines. And I think that Richard has already mentioned them. They work by binding this GABA receptor, and this is an inhibitor receptor. So essentially, once they bind to the receptor, you have an inhibition of the neuron, of the second neuron there, instead of an activation. And therefore, they are called depressants of the central nervous system, which is linked to a range of dangerous adverse effects, obviously sedation, but respiratory depression and coma. So they are particularly worrying in the sort of late stage of the illness where respiration may be compromised. And it can make something like pneumonia much more dangerous. And also in the elderly or in very kind of physically frail people, the risk is quite significant. This is a list of the most used ones in the UK. There are quite a few others that I'm not mentioning. And so I think we all know that they are incredibly effective to fix anxiety and agitation, and they often work very quickly. But unfortunately, with this medications, tolerance and dependence are unavoidable if the use is prolonged. And the other thing that people obviously don't know, or at least don't keep in mind, is that these drugs have an incredibly long half-life, and half-life is the amount of time that the drug stays in your system. And as you can see, for example, for diazepam, the half-life is about 4 days, which means that throughout those 4 days, every time that you're adding another dose, that dose is going on top of the previous ones. which is obviously quite a dangerous situation in which to be. And also, it is a little bit of a no-win kind of situation, because if you choose benzodiazepines with a short half-life, you are more likely to have rebound effects. So, for example, I never use lorazepam with my patients because we do know that what happens is that once the lorazepam is no longer in the blood at a good therapeutic dose, often you have this rebound effect. So the neuron kind of come back, with a vengeance in terms of causing even more anxiety and agitation than we had before. And that is something that is very important to keep in mind. On the other hand, if you go for those with long half-life like diazepam, unfortunately here, as I said, the risk is accumulation, and the most common side effects with that, adverse effects of accumulation, are falls, confusion, and hypotension, which will be very, very relevant to anyone with Huntington disease, particularly in sort of more advanced stages. So what's the alternative when somebody's agitated? I think we said that, in fact, that there's lots of different approaches, but it depends if somebody is able to engage in other, for anxiety, for example, in other therapies like talking therapies, so relaxation techniques or mindfulness. These are all very helpful. In more advanced stages, when it may be difficult due to cognitive difficulties to engage in this, there are other options like sensory stimulation, aromatherapy, music therapy. So there are different things that can be tried. But my really strong advice is that if it is felt at this point that the pharmacological intervention is required, I think it's important to seek the advice of a psychiatrist, because it is actually counterintuitive, because anxiety is so common, but the management of anxiety is very complex. And I will briefly show you in another slide, which I got from a recent masterclass for consultants in anxiety management from the British Association of Psychopharmacology. And I was pretty shocked in terms of how complex the protocol is. And I mean, lastly, for severe agitation, it's always important to carry out a very comprehensive assessment, looking at all the possible causes, which can be environmental, can be, as Rachel said, other causes, other physical problems. Often communication difficulties can cause anxiety and agitation, because obviously it's incredibly distressing not to be able to communicate. And if you have to, you can consider some medications that would work. And the first choice should always be for medications, for antidepressants that are calming, like mirtazapine or trazodone, while neuroleptics, due to the side effect profile that we mentioned earlier, they should be really used as a last resort. And this is quickly what the anxiety treatment algorithm that I was mentioning. Obviously, we don't need to go into it, but it's just to kind of show that it is not something that should be, this is something that should be left to the specialists. And also, what's important with anxiety, and I have tried to ask people, and often I get the opposite answer, because in fact, paradoxically, the treatment for anxiety should be much longer than the treatment for depression. And also, quite a good number of people, if they stop the medication that they were on, will experience discontinuation symptoms. So it's very important, particularly if these people can't communicate clearly, to recognize those as discontinuation symptoms, as opposed to thinking it is a relapse, and then you go back on the medication, which was unneeded. So I think that Rachel has discussed this already, but I really wanted to emphasize, because I think there is this concept of diagnostic overshadowing, which I think is very important for Huntington disease, because it's such a complex and also lifelong cognition that we see this a lot. So actually this concept was developed in mental health, and it is a concept by which if you have a diagnosis of a mental disorder, let's say schizophrenia, all the symptoms for that experienced by that individual would be attributed to that disorder, ignoring other causes. And this happens a lot in HD, in my experience, unfortunately. And also very often it is overlooked what I discussed earlier, that obviously, if you have an anti-disease, you're still going to have the same conditions that everyone else has, particularly related to age, like high blood pressure or diabetes or high cholesterol. So all of this has to be taken into consideration, as well as drug interactions that also Rachel mentioned earlier. So it's really important that any prescription of psychiatric medication or alteration of psychiatric medication should be done after very careful consideration of all these factors. Whoops. I think I jumped to the beginning. So I think I just had one last summary slide, which take-home message, which in fact we have already sort of discussed. So at all costs, avoid unnecessary high doses and polypharmacy, because those are the two things that will cause side effects. You stay simple, minimalistic approach and low doses, then you're safe. Medication should always be the last resort after everything else has been explored. And also, especially for professionals, be very wary of diagnostic overshadowing and always consider every other possible cause of the symptom, not just think of Huntington's disease in the first place. And that's it.
Thank you very much, Stefania and Rachel.